He has been the editor to the Journal of Digestive Endoscopy, section editor to the Annals of Gastroenterology. He's the associate editor to the Digestive Disease Sciences, Journal of Postgraduate Medical Education and Research. He is the member of editorial board to the reputed journals like Gastroenterology Endoscopy, Journal of Gastroenterology and Hepatology, Endoscopic Ultrasound, Indian Journal of Gastroenterology, World Journal of Gastroenterological Endoscopy. He has been mentor to various students in the Center for Biodesign at PGI Chandigarh. He has multiple accolades that was bestowed on him, including the Don Wilson Award, postgraduate grants by European Society, Young Clinician Award, and Young Scientist Medal from the significant contribution of research in gastroenterology. I think we can have no better person than him, a young clinician who has made up to the heights of clinical sciences, to talk to us today on the expectation of clinicians out of hospital administrators. Because going forward, as hospital administration is becoming a very important and a professional subject, it's very crucial for us to understand this perspective of the clinicians so that we can help better the system. Thank you so much, sir. Over to you.
Thank you so much, ma'am, for the kind words. At the outset, I would like to thank Dr. Yashpal, yourself, Dr. Vipin Kaushal, and the office bearers of AHA for inviting me and giving me an opportunity to speak in this webinar. And at the outset, I must admit it's a very challenging topic for a clinician to talk on administration. And frankly, administration is just for 2 to 3 years I have been into that, and I have little bit experience, but much more experience as a clinician. And whatever I have learned and seen, that's what I've tried to put down in the next 15 to 20 minutes. I've gone through some of the things in the literature, and I will try to present what a clinician expects from an administrator after having been put on the administrator's shoes for a few years and seen the challenges of administration. So I'm not going to talk about unrealistic expectations, but I'm going to talk about realistic expectations where we tend to maintain a balance and ultimately achieve the aim of delivering a quality care by working as a team. So I'll just share my slides. So are my slides visible to all of you? Can you see the slides?
Yes.
Okay, fine. Thank you. So as we all know that there has been a paradigm shift in healthcare delivery. From me, it has become we, and that's what we have to adapt to this new change. If you look at in 60s and 70s, hospital worked as open workshops where the physicians treated patients without any administrative oversight. However, presently, the physicians are employed by hospitals. So this presents a number of unfamiliar challenges for physicians for which they have not been trained in their medical schools. They have to follow the official procedures. In private hospitals, report to managers and navigate ubiquitous red tapeism. Because of these changes, both physicians and administrators have struggled to adapt their relationship to evolving paradigm of clinical practice. Now, what physician has to learn is that the healthcare delivery is now a team effort and it's not an individual effort. There is a paradigm shift from an individual care to multiple player involvement. However, unfortunately, still there is no formal teaching in medical schools about collective healthcare delivery systems. The medical schools still continue to provide academic and competitive environment, roles of management, finances, and leadership. There is no formal training. And physicians are increasingly working in teams and large complex organizations. The ways of thinking and working that serve doctors and patients well in much simpler circumstances of individual practices are no longer enough. The physicians need to learn to think strategically rather than only clinically. The physicians, however, tend to be reactive because they are driven by science and suffering, and they are also uneasy with being led. They are too individualistic, and that's inherent because of the training and competitive environment to which they have been exposed in their medical schools. However, you look at administrators, they tend to be more comfortable with working in teams. because they understand as a part of the training that complex decisions are best made by effective teams and team can work through conflicts. Many doctors are too inclined to dominate the teams, and administrators are generally more comfortable with conflict and negotiation. The best strategy for negotiation is win-win and not win-lose. That's what is the mantra for administrators. However, the doctors or the physicians are too inclined to see negotiation as a process of extracting concession from the other side. And again, that's because of the inherent competitive training in the medical schools. So this table summarizes the way a physician and an administrator thinks and works. If you look at physician, they will focus on an individual patient, will not be primarily concerned with cost. For a physician, the patient care is the most important, and he has to face contact with patients and families, is expected to solve all the presenting problems, because as a clinician, we have been trained that all problems are solvable. So we tend to find a solution for all the problems. And we have been taught to be independent and competitive and trained to emphasize the scientific approach. And we expect that all problems have solutions. On the other hand, if you look at an administrator, they are focused on population groups and government agenda. They are focused on the treatment being efficiently delivered within allocated resources. They very rarely meet patients or families, so they are not at front line. They have to choose which problems to tackle, because for them, they have to prioritize the problem. All problems are not solvable in their perspective. They are expected to share responsibility with others, so they work in a team effort, has to remember the political factors and human motivations while delivering the patient care. And they are expected to tolerate many insoluble problems, which is not a perspective which a clinician carries. So then doctors and administrators have different cultures, which opens up possibilities not only of fruitless fighting, but I think also of rich learning from each other. So with this background, what I'm going to talk about in the next 15 minutes is just try to learn what does a physician wants from the system. What do physicians traditionally feel about administrators? What do physicians expect from administrators? That's the main topic for this talk. And on the other hand, also try to look at what do administrators expect from physicians. But then again, this is a topic not being much debated or discussed, because many people feel that the administrators are policymakers and they can get their way through because they are the enforcing agencies or enforcing people in a healthcare system. And then after learning all this, I will also try to briefly summarize how to work as a team to improve the healthcare delivery. I must admit that challenges may be different in government and private hospitals, and my perspectives are mainly from government hospitals. And I am not going to talk about the finances and other issues which come in between the administrators and physicians. So what does a physician want? I'm sure many of us of our generation would remember Dr. Leonard McCoy from the Star Trek in Starship Enterprise saying, "Damn it, I am a doctor, not a bricklayer," or "Damn it, Jin, I am a doctor, not a moon shuttle conductor." So we have gotten into field with the prime expectation being helping people, being physicians. That's what most of the clinicians feel. So, but now once we get into the field, we find that there is a lot more to it rather than only treating patients and believing that we are only doctors. So once the physicians walk into an hospital onto a floor, anxious to begin caring for patients, but then they run headlong into a wall of administration. The perception among the clinicians is that the physicians are being increasingly strangled by administrators. The typical physician's view of management is that administration is boring, uncreative, and best left to those incapable of doing anything better. That's the general perception which physicians carry not only in India, but everywhere in the world. Even in the literature, if you look, the people will talk about the same way when you look at the surveys of physicians about the administrator's perception. The physicians are concerned about patient-doctor relationship, and that's what have been the foundation of ethical teaching of the medical graduates. However, over the last 3 decades, a new sort of relationship has been created, and it's our responsibility to nurture it properly. That is a relationship between a physician and an administrator. Now, this is a survey which was done in US, where 54% of physicians working in hospitals reported loss of enthusiasm for work, feelings of cynicism, and low sense of personal accomplishment. And then they found that this is because the fault lies among in the healthcare administrators. That was the perception of the physicians. The only question which they asked was why there are so many administrators involved in the delivery of care now when there were so few in early days of our career. So many of us who were graduating, we didn't find so many administrators, but now once we are working into clinical practice, we find each hospital has a huge number of administrators. So in this survey, the survey concluded that the physicians felt that everything would be better if my administrator colleague just backed off and let the physicians take back to caring of patients. So if we look at this survey and the conclusion of this survey, it reiterates the fact that the relationship between those who deliver the care, that is physicians, and those who administrate, that is administrators, has never been more tense, challenged, or fractured. And I'm sure many of us would have witnessed this. So just as a patient-doctor relationship is pivotal therapeutic relationship in medicine, I feel interaction between a doctor and an administrator is central to delivery of a quality clinical care to the patients. So main difference that inevitably causes tensions between the physicians and administrator is physicians have an individualistic focus about healthcare for the patient in front of them. And on the other hand, the administrators take a broader perspective with focus on maximizing resources and providing best healthcare within the identified budget or the resource constraints. So in last 3 decades, despite so much of advancement and increase in number of physicians and administrators, where did we go wrong? I think this is a true fact of life that change is hard, and the healthcare industry is changing more rapidly than anyone is able to keep up with it. The relationship between those who administer and those who deliver, because of this change and difficult to adapt to this change, has got strained. Both groups actually don't understand each other, and because of this lack of understanding, don't trust each other. So solving these challenges will require a distinctly different type of relationship between physicians and administrators than that currently exists in most health systems. So as I was talking about, there has been a disproportionate growth of hospital administrators. There is a data to prove that. This US data between 1975 and 2010 showed that physicians grew 150%. That's proportionate to the population growth. However, the number of administrators grew phenomenally to 3,200% in these 35 years. So is this increase in the number of administrators good or bad? The supporters of increase in the number of administrators suggest that this increase is needed to navigate changes in healthcare delivery, including advances in information technology, new regulatory requirements that are to be enforced, and unprecedented levels of scrutiny at different levels, which can be provided only by administrators. However, the critics of this increase in growth suggest that the increased administrator growth increases physician burnout. The growth of administrators have resulted in increase in rules, regulations, and management procedures. For physicians, the focus has always been patient. There is only one person that makes key decisions on behalf of the patient, and that's the doctor. So the physician feels that the management procedures and regulations is actually a burden on the physician, and increased administration will translate into clerical fatigue and tedious documentation. So the physicians feel that this growth in healthcare administration should in some part be a tool to relieve the physicians of administrative and clerical burden rather than increasing it. So after listening to all these things, what's the bottom line? The bottom line is the physicians alone cannot solve the healthcare biggest problems without the help of talented, dedicated, and multidisciplinary administrators. So both have to learn to coexist and learn from each other. Nor these administrators can solve the same problems without the robust and thoughtful engagement of physicians. So I think it's important to stop blaming each other. Physicians have started blaming administrators for creating administrative hurdles that diminish their autonomy and increase the workload. Administrators blame the physicians for failing to work as per standard operating procedures, as well as compliance to resource constraint, resulting in difficulty in providing quality patient care. And this blame game is affecting the patient care, the care gets disjointed and damages the workplace culture. So both have to develop basic understanding of each other's responsibilities, perspectives, and values. So before expectations, I feel comes proper understanding on respect of each other. So physicians and administrators share common core value, that is service, altruism, and acting on challenges. However, they differ in approach and knowledge base. Physicians are focused on delivering patient-centered care, where administrators are focused on managing resources. Physicians are trained to think patient by patient, whereas administrators are trained to create system-level changes. And these differences are significant, and gaps in mutual understanding can spawn distrust on both the sides. So to successfully rebuild this relationship or partnership, both should learn to walk in each other's shoes. And that's, I think, is the bottom line of expectation from each other. One should learn what other is doing. So what are the expectations of a physician with an aim of improving healthcare delivery? So I'm going to talk about the expectations which are realistic and which are important in transforming the healthcare delivery. The first and foremost is one should involve the frontline physicians in decision making. We should formalize the processes and structures to unlock ingenuity and knowledge of frontline physicians. Although we have built broad-based committees and coalitions, but physicians sitting on most of these committees are almost always part-time administrators and almost never true frontline clinicians. Even best intentioned clinical administrators often lose sight of the micro level insights that drive improvements in care or delivery. So hence, it is very, very important for frontline clinicians to be involved in decision making, because they are the ones who are fighting the battle at forefront. So unless and until their feedback is taken and they are part of these committees, the change is not going to happen. If you give physicians greater say in decision making, this will increase their commitment to change. And management-led organizations, whenever they try to enforce any change, the physicians are resistant to change. The physician engagement must be beyond tokenism, and there has to be increase in number of channels of communication to voice their concerns, and their voice should be heard by the administrators. And there has to be an increased face time. That's a bottom line. So more you interact, more you involve in decision making, you are going to have a better patient care being provided. And it is also very, very important to involve the lowest most clinician, that is the trainee, to the faculty in decision making, because each one is going to have a different perspective of the challenges and problems being faced in patient care delivery. We should respect each other. So one should adopt a distributive leadership model. So by sharing the leadership between administrators and physicians, one can increase the physician satisfaction. And there is ample data in the literature which has shown that when the leadership is shared between administrators and physicians, the patient quality care delivery improves, as well as the various parameters of satisfaction of physicians also increase. So it is important to solicit quality improvement ideas from both physicians and administrators, and together brainstorm solutions to problems. One should also empower the physicians. All physicians, in addition to being responsible for the delivery of healthcare, should also be made responsible for redesigning the healthcare. This type of empowerment would lead us to genuine insights that enable us to collectively improve the patient care. So getting the culture of physician engagement right and valuing all physicians for special insights that they can bring to the delivery is critical foundation for value-based healthcare delivery. Another important expectation is that we as a clinician expect that administrators should teach us about administration also. So it is important for educating physicians about financing of care delivery. Most physicians like me have completed their training with little or no knowledge about financing or organization of healthcare. Nowhere in their medical college or residency or fellowship, we physicians get a comprehensive education on healthcare policy, administration, finance, or organizational behavior. So because of this lack of formal training, most of the administrative training which we get is an informal training with an experience only. No wonder, because of this lack of training, there is a suspicion between those involved in administration and financing care and those who are involved in actually delivering it, that is the physicians. Just imagine how different would be the healthcare system if the administrators devote 10% of the time to educate their physician colleagues on financing and administration of healthcare. So I think teaching physicians about these two important aspects of hospital delivery or healthcare delivery is going to make a phenomenal change in the way physicians look at the administrators. The other side is also true. The administrators should also learn about the nuances of clinical medicine. It is very important for the administrators to be taught about the clinical medicines. Very best administrators, if you look at the history or at the literature, the rest of the administrators had very deep, intuitive understanding of clinical medicine that enabled them to speak the same language as their physician counterparts. So thus, meaningful bridges would be built that otherwise would not exist. So understanding how the care is organized and delivered on front lines by an administrator can help create a deep mutual understanding and a genuine respect for each other. You just imagine a situation that framing collaborations in terms of buzzwords like population health, value-based healthcare, those involved in hospital administration came to the boardroom or committee rooms talking about the details of improving the care of patients with specific diseases like diabetes, pancreatitis, or gastrointestinal bleeding. So if an administrator has a knowledge of the clinical aspects of medicine, it's going to bring in respect from the physician for the administrator. So it is important to learn about each other, improve mutual understanding of roles, teaching clinicians about business of medicine. When physician understands how administrators make decisions around financing, delivery, and operations of healthcare, fewer misunderstanding is expected. And we should also embed basic training in operations, finance, and policy in clinical rotations. It is also equally important to train administrators on nuances of clinical medicine. In many of these meetings, administrators will struggle to understand the clinical speak, which is actually the way the clinicians speak, and get frustrated when the administrative changes fail to drive the clinical improvements because of lack of this clinical speak and lack of understanding of the physicians. So this is what I call that there is a need for clinical shadowing of the administrators. That means observing clinical procedures, walking through the wards while the clinical rounds are going on, or being in OPD during the OPD hours with the physician colleagues is going to make a broader clinical perspective for an administrator, and this can help in making good administrators. By bringing administrators close to the clinical care, distance between the boardroom discussions and the real world setting can be bridged. Another important expectation is that the hospital administrators should respect the physicians, and I think it's more important for corporate hospitals rather than government institutions, because in corporate hospital there is a new trend where the clinicians are being labeled as healthcare providers and not as physicians. So what healthcare industry has started doing is to refer to all clinicians, physicians, nurses, pharmacists, and others working in hospital as providers. So patients don't seek providers, but rather they want great clinicians who will care for them. So when we only refer to physicians as providers, we probably are inadvertently devaluing their clinical training, the work that they do, and their contributions in providing quality patient care. So after learning all these things, I think what's the vision forward? What's the way forward? The frequent cause of this disconnect is poorly defined vision. And the reason for this is all physicians are tied to their profession and administrators are tied to their organization. So finding a common ground is very, very difficult. And this common ground is what we call as a shared vision of care. So the vision of need of patient is first. So both physician and administrators can tailor their work onto this common shared vision. So a patient-centered culture can help administrators demonstrate their commitment to provide high-quality patient care and restore physicians' trust in managerial decision-making. Understanding and articulating responsibilities of both physicians and administrators is one of the better ways of defining the duties and bringing in harmony in the work. And one should identify the operational vision which is consistent with these responsibilities which are being assigned to both the physicians as well as the administrators. Another important issue and expectation is that the administrators should preserve the physician autonomy. A physician enters medicine for patient care and should not be burdened by a barrage of rules, regulations, and reporting systems. Many times in many healthcare institutions, despite their expertise in patient care, clinicians are forced to follow directions about the patient care from the non-clinicians, that is administrators. And without clinical autonomy, a physician burnout is expected. So administrators should engage physicians in active problem solving rather than passive rule following. And when physicians are empowered to make informed decisions, a physician administrator alignment will automatically follow. So delivery reforms require robust engagement between both. Physicians and administrators both rightfully consider themselves to be highly trained, skilled, and knowledgeable. And physicians may feel that administrators don't understand or don't care about challenges they face taking care of patients. They may also feel that they are treated as line production workers with little control over their schedules, support team, and even clinical decision making. And this should not be. They should be involved in decision making about the aspects in which they are directly involved. So to summarize, the key points are: the expectations of a physician is one should not be having a top-down executive mandate. It should be a collective decision making. Administrative decision making not to be siloed. There should be increased transparency around the decision making, and there should be more avenues for collaborative decision making between administrators and physicians. So finally, what has been my experience? I have been predominantly involved in clinical work and research, and of late have little bit exposure to administration. So what I found initially was, when I had very minimal exposure to administration, I felt it to be a boring, uncreative, and a hurdle creator job. But then later on, I had an exposure to both the cultures. I had been on both the boards. Administration is able to mix together the ideas, people, and resources to make things happen. And it is a creative job, a difficult job, and a real privilege to work in the shoes of an administrator. And it is more challenging. There are more uncertainties in management as compared to uncertainties and challenges in medicine. So to conclude, a proper healthcare delivery will require a robust engagement between administrators and physicians and a better understanding of expectations of both. Physicians should learn about leadership, strategy, system thinking, negotiation, genuine team working, organizational development, economics, and finance of healthcare. Also, the administrators should learn about creating an evidence based in their practice, encourage research-based debate in administrative rounds. It should become a full profession with sound scientific basis, and also learn to stay close to the patients. In the end, ladies and gentlemen, mutual learning could lead to a harmony that would benefit both the groups and, more importantly, the patients. And in the words of Simon Sinek, a team is not a group of people that work together, but a team is a group of people that trust each other, and then only a quality team is formed. Thank you so much for your patient hearing.
The house is open for questions.
Yeah, thank you very much, Dr. Rana. We're really grateful to you that you came here and give us an excellent presentation from the perspective of a clinician. Although you rightly said that we have to work as a collective healthcare delivery team, and teamwork is must. And out of my experience of 30 years, I can only say that we have been working as a team only, and wherever possible, the clinicians are involved in the decision making. Nowhere decisions are made in isolation. Like, I'll give you example of Jammu and Kashmir Medical Supplies Corporation. Although it is only dealing with the procurement, but all decisions are made by the clinicians only. If I have to procure certain things, like I have to procure some equipment for whichever department, I start from getting specifications from them, and then getting those specifications vetted by them, and then calling them in all pre-bid meetings. Finally, the technical evaluation and final selection of the equipment happens with their consent only. And what we are taught in the hospital administration is that you have to work as a team, and our basic job is coordination in the hospitals. So that we have been doing, and it's really nice of you that you spoke so openly about what you expect from us, and we have here our very senior colleagues, even Dr. A.K. Gupta has also joined, and then we have Dr. Kapoor and many other. I would like to, them, Dr. Siddharth is here. They're much more experienced and they are running big organizations. Dr. Vipin is there. So I'll request them to, give their point of views. Dr. A.K. Gupta wants to say something. Please unmute yourself, sir.
Yes. Sir, you have to unmute yourself. We can't hear you.
Okay.
Yeah.
Am I audible? Firstly, regards to Air Marshal Pavan Kapoor, Professor Siddharth, Professor Dr. Jaspal Sharma, my colleague, Professor Vipan, and Nagarajan, and all of those. Absolutely, I have worked with Professor Surinder Rana for a pretty long time. I will yet to come across a more dedicated physician than him. And I'm very, very happy that he has done a very huge, excellent presentation. But I will have a little add to everybody. There is no observation against anybody. But let me tell you that patient comes to the hospital for the doctors. They don't come that there is a renowned gastroenterologist, Professor Rana. They come for that. They don't know there is renowned hospital administrators. So one thing is the doctors and the nurses are central to the hospital. That clinician must know. And anybody who feels that he is more important than the patient or the physician is doing a disservice to his profession. Number one. Number two, to the clinician, I will say I have one thing I must share. Gone are the days 30 years back. 30 years back, there was no loss. There was absolutely no accountability to the doctors. Today, you do the wrong thing and the people go to the court of law. You do the wrong thing. There was Consumer Protection Act, BCP, NDT, many doctors have gone. There is biomedical basement, lot of trade union are there. And the worst thing, I will not take credit because everybody has contributed. Let me tell you, my 26 years as a medical superintendent at PJ Chandigarh taught me that present government won today's information yesterday. So that possible only when a hospital administrator can do. And the law, the qualities, the conflicts, the complaints, the parliaments, all these things, the clinicians unfortunately don't make it. The brighter the clinician, lesser will be incompetent. He will be in the hospital administration. And I think without naming anybody, those topmost clinicians who headed the organization messed up many things. So all said and done, 30 years back, there was no accountability of the doctors. There was no accountability by the hospitals. There was no acts. They don't have to submit a series of reports, be it biomedical based management, right to information, be it THO. All these things are done that hospital administrator has to do. And that's the reason I can say that we at PJ Chandigarh, with the help of the clinician, I must say PJ is very, very good that they have always kept the clinicians in the loop. I never took any decision without involving clinicians. So overall, without delving further, thank you very much for a very good presentation. But then clinicians do have to go to the quality of the patient care services and quality of the life is increasing. The more laws will be coming to the play, and more accountability will be built on hospital, on clinician, on administrator. And you very rightly said we have to develop a more team, better teams. And unfortunately, workload is such that time constraint, there are so many diverse demands, it is not possible. Yet, I must say, the institutional like AIMS, PJ are doing good job, and they are bringing lot of awards. If you see into the awards which the government has provided, most of the institutions where the hospital administrators are involved, they are winning this. This is all the contribution of the hospital administrator in running the hospital successfully, winning accolades, winning the confidence of the people, and making the doctors, the clinicians work more comfortable is undisputable. Thank you very much. Over to you.
Thank you, sir. Dr. Mahesh Devnani, you had a query.
Sorry. Yeah, thank you, Dr. Sharma, and thank you, Dr. Rana, for this presentation. I raised the hand earlier, but I think Dr. Gupta has already mentioned that thing. That one thing that I wanted to add just to what Rana said, that one area where, based on my experience, what I have understood it, what I have seen is that physicians' expectation is in the fields of law. Many a times, whenever they face issues related to statutory provisions or the legal issues, they actually look up to the administrators to help. And this I have seen in personal experience also, whether it's a Consumer Protection Act issue, whether it is pertaining to the RTI or any other issue where they face problems. It is their expectation from the hospital administrators that the hospital administrators will help them in those issues. Another thing that Dr. Rana has mentioned about the training of physicians. So that's a very pertinent issue. And to some extent, I think all organizations do few things, not necessarily in the general administration thing, but for example, the procurement. We in PGI from time to time conduct workshops and seminars on procurement to sensitize physicians that it is actually what earlier the chairman, the president of the AHA also mentioned, that their involvement in the procurement is very important because they are the actual end users. So their understanding of the procurement process, their understanding of the difficulties and limitations of those procurement processes actually help the organization in overall getting better instruments, better equipments. But what I have, based on, because I was also the purchase officer for the institute, what I saw that many times the physicians are reluctant to be part of that process, even if it is preparation of these specifications. They actually are a bit reluctant. So for that also their sensitization is also necessary to be done.
Yeah. Thank you so much, Dr. Mahesh. Dr. Rana, would you like to comment on this? Respond to this?
No, but there's nothing to add. I think I agree with all those things. These are all pertinent points. And, hearing from such experienced people, they have decades of experience in administration. So these all are important things. I think all these points are all are actually in practice in PGI. I think if I look at the administration in PGI, all those things are actually being practiced. I think few issues which I feel would encourage the physicians would be administrators being at frontline. If the administrators are with the frontline clinicians, looking at their problems daily, being with them, that probably would transform the way the things are actually going right now.
Sure.
Yeah, I'll just make a few quick points. Dr. Rana, wonderful presentation, and the 2 or 3 points that I wish to sort of highlight is you have given the example of the context of the administrator's perspective and the physician's perspective from United States of America. Now, if I know correctly, in United States of America, we do not have physician administrators. Generally, most of the administrators who are in the United States of America, because 80 to 90% of the healthcare is driven privately, they have from the business schools. On the contrary, if we look at India, what we find is that AIMS in 1956, when it was established in 61, our department was established. Soon after it was started at AFMC, then it was started at SKIMS and other places. And in the entire history of, let us say, All India Institute of Medical Sciences, there were only 4 non-physician administrators who did the, residency program in administration. And from 2016, when we moved to the MD program, that was the time when I had made a small presentation in front of the Dean's Committee, because that's the channel at All India Institute. And what we found was that by virtue of the fact that most of the administrators, at least at AIMS, PGI and other places, are actually themselves trained physicians, that doctor speak or medical speak part is generally taken care of. So that is one thing that I wish to, sort of highlight. And if we look at the growth of the hospital administrators as a specialty in India, I'm sure, this language barriers between clinicians and administrators probably would not be that big an issue if we carry out a study here in India, let us say a multicentric study. I'm sure that we will not find. So the second thing is, sir, that, I absolutely agree that when we were, medical students also, I recall way back in the 80s, and maybe, Dr. Gupta and some others probably in the 70s, medicine was relatively much more simpler. Now, not only the society, but also the delivery of medicine has become so complex that even we as administrators who are, trying to be on the fringes, on the lookout of, what new is happening, we also at times find it, difficult to keep pace with the changes that are happening in the world. I mean, to give a small example, procurement in government institutions. 2019 GEM was launched, GFR was changed, and there have been at least about 30 amendments in the GEM itself. So, from version 1.0 to version 4.0, some change somewhere, some other change somewhere. So if we look at it from a systems point of view, probably, what you have said very rightly, that from me, it has to go to we. And the second thing is that if we interact more, as you have very rightly said, probably, this the trust will, increase much more. We will be able to understand it better. And ultimately, the result would be definitely very, very good for the, not only for the patients, but also other internal stakeholders. Because you see, other than, medical people, there are, at 7 or 8 important cadres of employees also in the hospital. I have, heard this at AIMS that, AIMS mein to sirf faculty ki chalti hai, to quote, unquote. There are other cadres also. So we have been trained to forget our physician training during MBBS, during the administrative residency, to look at this side of the, story also. So probably, the way forward in India, at least in a complex scenario like India, would be to have more physician administrators, especially at the policy making and the, at those levels, so that they are able to appreciate not only the medical part, but also the administrative part. But I 100% agree with you that, more of, trainings or workshops for the clinicians. At AIMS, of course, we have this example. There is not a single committee generally that would probably not have, clinician, representatives. It could be faculty, it could be residents. But yes, bringing it lower down probably is something that I will take from your lecture, that you have the frontline people also in the committee as representatives, so that they are able to sort of tell what are the things that need to be addressed more. So that definitely, we can take. So these are some of the points that I would like to
I
add.
see Dr. Singh also wanting to ask some question. Please go ahead.
Hi, this is Dr. Singh. I'm actually a colleague of Dr. Yashpal Sharma and currently practice in US. It was very nice presentation by Dr. Surinder. Although, certain points are similar here also. I've done a master's in healthcare administration also, as Dr. Yashpal Sharma would know. We do have, as Dr. Siddharth mentioned, we do have physicians who take the role of administrators, but then often we see their stance almost changes, and they are dictated by the rest of the C-suite personnel. And often they forget that where they were before and where they got the support to get into that position, they completely kind of dismiss that. And there is a big disconnect, because often we see the racial bias also in our community hospitals too. Like most of our hospitals, they are controlled by Jewish community also.
Okay.
So often if somebody else who's a capable physician wants to get into the administrative part, they get a lot of issues thrown at them, and they cannot practice the fruitful medicine versus administrative role there. So, I mean, I see, I don't have any knowledge or practice while I was in India about all these, but there are certain common issues which we need to resolve in order to fulfill a healthy atmosphere for patient care. And beyond that, certain regulations like electronic medical records and other rules, which has taken a very,
Right.
it has caused a lot of burnout in physicians for not even benefiting the patient care. So that part, I don't know how it is in India, but this plays a major role in physicians leaving their practices, beside being overruled by the administrators. So there's a lot of work to be done to connect, and I don't know where we'll find a common ground to improve the patient care. So that's what I would to just comment on. But it was a very nice presentation. It's about 6 o'clock in the morning. I had to really get up. Thanks to Dr. Sharma for sending me the link.
Thank you. Thank you. Thank you, Dr. Ravinder, for joining.
Thank you, Ji.
Thank you.
Pawan sir, you have something to comment on?
I have a lot of things to say, but I heard everybody first. Yeah, I know what between what Dr. Rana gave a wonderful presentation. Firstly, my compliments to him. And if you add on between what Dr. Rana said, what Dr. Anil sir tried to bring out, the complexity of care over the past 30 years, how everything has become so complex, and something what Dr. Siddharth has pointed out, physician administrators in this country, what Dr. Yashpal shared some of his experiences. So between all of them, the topic is complete. Okay, the discussion of the topic is complete. I will only simply say two things, as whatever I've experienced in my so many years of care and being in administration at various levels, right from a resident till the topmost level in administration. There are two things which one thing which Siddharth brought out, which I'm a very great this trust factor. This is the main thing. The physicians by nature are always suspicious of the administrator, whether you are a physician administrator or you are a full-time, full-fledged administrator. The physician say, "Aa gaya administrator hame pakadne ke liye." He has come to catch us for something. How can this be removed? Now, can be removed by one of the terminology both Dr. Surinder Rana and Dr. Siddharth spoke as clinical speak. Medical speak or clinical speak. The administrators, being physicians, after some point of time, forget the clinical aspects of that administration. And therefore, if an administrator looks like to be a facilitator for the clinician, if he is perceived to be a person who facilitates the clinical working environment, the physician will take 2 steps forward to come forward and support the administrative decision making. But moment the physician perceives that he has come to hold me accountable and come to check on me and monitor what I am doing, who is he? Then ego problems start coming in, that you are not a frontline worker like me. How can you comment upon what type of delivery I'm providing? You don't provide me with the resources. Then you have no business to tell me how should I be doing my work. These type of questions come in. So the administrator should look like somebody who is facilitating the clinical working environment. Create that perception. This will come by ensuring that there is no role ambiguity. The role should be clear that the administrator is here to facilitate you, not to control you. Moment the physician gets this feeling, I can assure you he will take 2 steps forward, not only to be actively participating in your committee meetings, but also contributing to the quality of healthcare and contributing to administrative decision making, which at times may be far more superior than the solo administrative decision taken by the administrator himself. So this is one factor which we need to build in by practice, not by teaching. No matter how much hospital executive program you do for physicians, they will not learn the procurement process until unless they get involved with it physically. So therefore, they have to be involved. The involvement will come when the suspicion goes away. And that will come by initiative to be taken by the administrators to promote the clinical working environment and facilitate it. So that is my one line, this thing, solution to this. It will happen, it will be there, it is natural, but somebody has to take that step. As chairman of the Education Committee of NABH, every assessor writes, there is no involvement of clinicians in quality, improving quality care or improving quality projects or taking part or participation in patient safety programs. Invariably, 95% reports mention this. Nobody has given a solution that how the clinicians can be involved into doing this activity. So this is what I have also told NABH, please go back to the environment and tell them how to involve the clinicians in your quality. They are focused on quality, but their perception of quality may not be matching with your perception of quality. This perceptual gap has to become congruent as a congruent in between the two of us. Once it becomes incongruent with each other's, problem is solved. Thank you very much. Thank you.
Dr. Vipin?
Thank you, Dr. Rana, for the wonderful talk. And I go with General Kapoor sir's vision that we should look like facilitators. Most of the time, we are looked as hurdle creators. This is what I wanted to say. So we have to work practically to show that we are with them and we are there to get the best of the services from them by creating a very good working environment. So as a hospital administrators, the expectations of the physicians, we should look forward, involve them more in the decision making. And as the President, Academy Hospital Administrator, you can take steps in those directions. This is all I have to say. Dr. Gupta has also said, Dr. Siddharth. So we should do it, as Dr. General Kapoor said, not by teaching, but doing it practically. So we should do that and get involved in giving best of the services as hospital administrators and win the confidence of the physicians. That is very important. Thank you.
Sir, please go ahead, sir.
I will use only one word for the hospital administrators. See, make the working of the clinicians comfortable and they will take care of you. And I can say it from the experience point of view, I became faculty member after 1 year of my MHA. Clinicians selected me. They made me associate professor within 4 years. Clinician made me. They made my working in PGI successful because of clinicians. The only thing was we as hospital administrators should focus on ensuring that the clinicians' work is made more and more harmonious, more and more comfortable. All their problems, all their challenges are addressed, and the success will be there. And I must say, this is what was my mantra, and I believe that whatever I achieved, because of the clinicians. My success has been attributed to the clinicians who supported me because I made sure that their working is made comfortable. Clinician is the most important person, and he is sensitive. Take care of his sensitivity. With all, I think the administrator must have learned a lot of good things from Professor Rana. Over to you. Sorry, I thought this was more important from my experience of 35 and two best institutes in the country.
Anybody else who has some questions, please, or some comments to make? I see Dr. Subhash Dadhich also, a senior surgeon from Andhra. So would you like to say something?
Yeah, I think one of our faculty members, Dr. Tej, who is at the NCI, wants to say something. He probably raised his hand. Yes, Tej, I think you can.
Yes, yes, sir. Sir, good afternoon, sir. Uh, and good afternoon, Rana. So, thank you for the insightful talk. Sir, I just have one query. As a physician, what is your opinion regarding the GEM procurement system that has been initiated? Is it for the good or for the bad? Has it affected the quality of procurement of medical items and devices? What is your take on it?
I think Dr. Siddharth has already answered the question.
I'll answer that question. You know, about a month back, Dr. Guleria chaired a meeting of the heads of the departments and the heads of those divisions which make procurements. A research section, for example, CMET, plus heads of the department. This was actually supposed to be a budgetary meeting, which was for the revised estimates, but then the discussions probably went on in the other way. I can tell you that more than 80%, and as chairman of the SPC at AIIMS and chairing two SPCs, IRCH, NCI, as well as the main DO office, more than 80% of the heads of the department and those procuring entities were absolutely, not happy with the system. And the reasons are very simple. The reasons are, although the intention to create a GEM sort of facility by the government might have been good, but the implementation left a lot to be desired. Without ramping up the supply side, they launched the program. And when we tried to procure, nothing was available. And then there were lots of issues, because you see, it was as if the government was deciding in a vacuum, right? So, they just went ahead and we were, having difficulties to procure items. We had some system of vendors which could give properly, items which are of good quality. Because GEM, you see, when you buy from Amazon, you're not sure about the quality until unless it reaches you. So in a hospital, these sort of problems were there for a pretty long period of time, maybe about 7-8 months, till they ramped up the supply side. Then gradually things became better, some changes were done. And now with the supply side having been ramped up, one is able to procure. But then some of the errors or some of the problems still occur, with regard to, for example, creating BOQs, certain items which are not there. Drugs, for example, are not there on GEM. So those issues are there, and probably over a period of time, they will also get, settled. So I can tell you the mood of the house at AIIMS, at least, 80% not happy, absolutely not happy.
Same in PGI. Not
Yeah.
happy with the GEM procurement.
In fact, being from the Central Procurement Agency, I would like to share my experience. GEM procurement is, you rightly said, it's not working properly especially for the health sector, because health sector, they have not registered a good number of vendors on the health sector, and all the items are not available. That is one part. And another part is, we procure most of the items on the rate contracts. So rate contract is for a particular period, let's say 1 year, 2 years, that's there. And we are in the process of procurement on those rate contracts. That facility is not there. We have been writing to them, but they are not responding to that. Although they're saying that they are working on it, they will be able to get the rate contract. You rightly said, drugs, only those drugs are available which are on with the PSUs, 132 or something like that. Some drugs are there. But other equipments, most of the equipments like AIIMS, PGI, you require all high-end equipments. So what to say of high-end, when the low-end equipments, the vendors are not registered on GEM. So obviously we are also in trouble. We are trying to first we go on GEM. GEM, earlier they were giving us non-availability certificate. It was
Yes.
coming up. Now
Yes.
even that is not there. They say entire BOQ is to be put on. You have a
Upload.
facility for tendering, and
Upload.
those facilities have come up. But after doing that, I can tell you that even 80% tenders are non-responsive. So that wastes a lot of time.
Exactly.
I waste a lot of time on that. Then I again come back to e-tendering. E-tendering on government portal is I think is a better option than the GEM procurement. GEM procurement, you still have the chances of manipulation. The government e-tendering process, the manipulation chances are less. So the experiences are not good. You rightly said that.
Okay. Any other questions?
Thank you.
I think, ma'am, there are two people who have raised their hands.
Yeah, Dr. Guru. Yeah, and Dr. Dadij.
Good afternoon, all the dignitaries of hospital administration and Professor Rana, sir. Sir, I want to request all of you that during COVID time, the role of hospital administrators was given to a great extent. And what we face the problem that we are very minimal in number. In the entire COVID hospital, we may be one junior resident and one senior resident, and one faculty and one very senior medical superintendent. Problem is that if we are dealing with all the residents, the junior residents of clinical departments, they are facing the problems which are being handled by a attendant. They do not know where to send the samples. They do not know in which vacuum container we have to put the blood sample. So all these issues has been arised, and we have tried to solve it by the use of technology, by making WhatsApp groups, by advancing our HIS system. I will request if our number can be increased. If our number can such that we can be posted in one, like our housemanship, we can be posted in one department only. Then we can learn the difficulties what they are facing, and we can help them to a great extent. This much, sir. Thank you, sir.
Thank you, Dr. Guru. Professor Rana, would you like to comment?
Yeah, I think, ma'am, it's a valid point. And the numbers in our country still are not as what the numbers are in West, because the data which I was quoting was from the West. We still are short of administrators. It's only in institutes like AIIMS and PGI where we see a lot of administrators, but in other hospitals, it is the physicians only who at the fag end of their career wear the administrator shoes, and I don't think so they do justice to that job.
Right. Thank you so much. Dr. Dadij. Dr. Subhash, kindly unmute. You had a question?
Hello, can you hear me?
Yes, sir.
Yes, sir. Good evening, everybody. I'm a surgeon and I'm based in Vizag. And I've been following the discussion. It's a very interesting discussion indeed. You are addressing the most difficult issue of how to bring the administrator and the clinician together. And I appreciate all the points put forward. But at the heart of it, I like to say that medical treatment has become very complex. There's a rapid increase in medical knowledge. Every few days, the knowledge is bounding. There are so many armamentariums coming up. The legal department is more important in medical treatment now, which was never there before. The information technology has become so rampant and is very important here. Can you hear me? Hello?
Yeah.
Yes, sir, we can hear you. So it is a team effort, like what you put it most correctly, from me to we is good. So what I'm saying is, at the heart of it, everybody wants to have the patient to have a good care. So in that case, the differences have to be solved, and the differences can be solved only by rubbing shoulders together. So for that reason, involvement of them in committees is good. But what I suggest is there should be a board of management of a big hospital in which there are equal number of administrators and clinicians, and all of them put their heads together and work. Now, the most important thing is the time factor. Clinician doesn't have time. So now with the presence of Zoom or these WhatsApp and in other ways, they can all be connected together, and any problem happening should be handle on real-time basis. You don't have time to waste. You can't file a complaint today and get it solved after a few days. So real-time information technology and involvement of the physicians on a day-to-day basis will make a big way. And another one, recently one of the doctors has said that we are very few in number, we should increase them. So what I suggest is, during residency in all departments, surgery, gynec and all that, the residents can do 1 month posting in administration. So they will also come to know their point of view, how things go. And in this way, I think the family of treating physicians and administrators can grow. And if that mistrust is gone, definitely the things will be better. That's what I think. And I think we should have more of this discussion in future. Thank you for giving me a time.
Thank you so much, sir. Thank you. Any comments?
Now you can close by thanking the dignitaries.
Sure. Thank you so much. At the outset, on behalf of everybody and Academy of Hospital Administration, I would like to thank Professor Rana for taking time out to have such an eloquent session on